Welcome to this Bone Matters session on how long should I be on my drug treatment. Today's session is about why you might be recommended to stay on one osteoporosis treatment for a different length of time, perhaps to another, and what the reasons behind this might be. So I'm delighted today to be joined by Dr. Zaki Hassan-Smith. Zaki, perhaps you could give us a brief introduction of what your role is and where you're based?
Great, thanks, Kirsty. So I'm Zaki Hassan-Smith. I'm a consultant endocrinologist in Birmingham, so University Hospitals Birmingham. So endocrinologists are normally they deal with hormonal disorders, but my real subspecialty is metabolic bone disorders and osteoporosis in particular.
Fab. So well placed to answer our questions today then.
Hopefully.
Yeah. So perhaps we could start by talking about the bisphosphonates. We get many questions to our helpline from people asking about how long they should be on their treatments. And you've got the bisphosphonates with alendronic acid, risedronate, ibandronate being weekly, or in the case of ibandronate, monthly tablets, which lots and lots of people are using. So how long can people stay on these?
Yeah, so these are really commonly used medications and really useful sort of within our practice. And with everything that I'm talking about today, the care is really individualized, sort of what is the best treatment for the individual patient. If we take the oral bisphosphonates, often people are prescribed those for an initial course of 5 years. And then there may well be some assessment at the end of that period, in order to decide on next steps.
Yeah, absolutely. And so is there a reason why people wouldn't be able to just stay on them long term?
Well, so in terms of benefits, you do see real benefits over those sort of 5-year timescales. And obviously, if you're at very high risk of fractures, then you may very well be advised to stay on it longer term. And there are many patients, where that's the best approach for them. There are some long-term follow-up studies, so some research studies, which have shown that some of the very rare side effects, they're still rare, but they can creep up with particularly prolonged treatments. So obviously, from our point of view, this is something that we follow up. And one of the conditions, and I would say the ROS website has got fantastic sort of resources and information, on this. But you may have heard of atypical femoral fractures, which are a potential long-term outcome. But as I say, they're low in incidence, but it's something to be aware of with prolonged treatments.
Absolutely, yeah. So we hear about pauses in treatment, or sometimes they get called drug holidays.
Yep.
Do they help? Is there a reason why people might be offered this?
Yeah, so treatment holiday is what the term people used to bandy around, which sounds quite nice, doesn't it? But I think there's sort of treatment pause. Often with the bisphosphonates, it can be a helpful thing to do, and particularly when you've got a patient in front of you, discussing things with the patient, you may come to the outcome that's the best approach. And effectively, often what will happen is that your bisphosphonate will be stopped after a period, say 5 years or more, and then there'll be some reassessment, in future, as to whether or not treatment needs to be restarted. Obviously, the reason for that is that the bisphosphonate medications are quite special in that they've got quite a long-term effect, and the effects build up over many years. So with bisphosphonates, the effects wear off very slowly. And we think for some patients that can be quite helpful to have some time away from the treatment in terms of risks and benefits.
Yeah, absolutely. And there's another bisphosphonate, obviously. Yeah. Lots of people might have heard about zoledronic acid. This one is an intravenous drug, so it's given via a drip. But
Yeah.
being another bisphosphonate, there's a sort of similar approach to it, isn't there? It tends to be used for 3 years. Is that right?
Yeah. So again, I mean, we use lots of IV bisphosphonates like zoledronic acid or zoledronate in our practice. And for osteoporosis, it tends to be given as a once yearly intravenous infusion. So often people will go to a sort of day case type setting and have their infusion. Now, and as I say, it only needs to be given once a year. And again, it's got the similar effects in terms of the effects wearing off very slowly after a course of treatment. So yeah, most of our patients who are started on that, we will prescribe a treatment course of 3 years, and then we will have a reassessment and a discussion around sort of next steps, what the best thing to do next would be.
Yeah, fantastic. And there are, of course, treatments that behave in a different way that don't come from the bisphosphonate family.
Yeah.
Some of the people listening to this or watching this might have heard about teriparatide, the parathyroid
Yeah.
hormone injections. This one is very different to the ones we've talked about before, isn't it?
Yeah. So with that medication, so that's a daily injection, and as I said, I'm an endocrinologist, so I look after sort of people with hormonal problems. And parathyroid hormone is a hormone, and this is a version of that effectively, which comes in a daily injection, and that's got its license in osteoporosis for a 2-year treatment course. And that's sort of based on the research studies, and that's the recommendation that it's used as a one-off treatment over 2 years. And what tends to happen with that, you only get your 2 years of treatment, and as I say, at the end of that period, there'll then be a decision on what to do next. Often the patients who are started on that medication, often they will need some further treatment after that initial 2 years, and things like bisphosphonates or some of the other medications I'm sure we might talk about a bit later, are options to move on to, sort of with that. In our practice, we quite often use a bisphosphonate, straight after the teriparatide, but we've got new treatments that are coming on the market, so that may very well change over time.
Yeah, absolutely. And the other one that we get asked an awful lot about at the moment, being that it's new, is romosozumab. It's a bit of a mouthful to say, but also known as Evenity. It's a bit similar in that it's, injections, and it's a bit different to the bisphosphonates, but this one's only given for 1 year.
Yeah, so initially, this tends to be when effectively if patients have recently had a fracture, so they've had a fracture in the last couple of years, and therefore are at risk of further fractures, and obviously there are more and more people. It's a newer medication. There's more and more experience around the world of people using it. We're at the early stages of getting everything implemented from that perspective, but effectively, as you say, it's given over a year, and then it's very likely that that patient group will then need to then move on to another class of osteoporosis treatment after that. We'll I'm sure you get more and more calls about that medication over the coming months and years.
Yeah. So we've talked about the bisphosphonates and a couple of other treatments. How long can you stay on denosumab? This is something we are regularly asked about on the helpline, and it's different to the ones we've mentioned so far.
Yeah, so again, we use a lot of denosumab as a treatment option, and it can be a really effective and helpful treatment. Initially, I think that a lot of people practiced in a similar way to the way that the bisphosphonates are used. But what's particular to denosumab is it's got a much shorter duration of action. So what's been recognised is once the medication is stopped, the effects wear off very quickly. So that could be a reduction in the bone density, and sometimes there's a risk of getting rebound fractures after stopping treatment. So it's really important, if you're on denosumab, that basically not to miss the planned injections. And at the end of a treatment course, often patients would have another medication. The other sort of way of practicing is sometimes, if denosumab is felt to be the best treatment for you, and somebody's at higher risk of fracture, sometimes the right thing to do is to leave a patient on it very long term, and to not keep going back and checking. But that's really individualized treatment, speaking with your doctor or your healthcare professional that's advising you, and getting the right treatment for you.
Yeah, absolutely. Yeah, definitely. And just to clarify, denosumab is the only drug treatment that we have for osteoporosis where we know about this rebound fractures effect. Is that right?
Yeah, so it is. So it's very well recognized, and obviously we've got lots of data from long-term follow-up studies where this has been recognized. Yeah, so denosumab's a particular case where you need to be aware of this short duration of action. So obviously, as I say, the main take home is, if you're having your denosumab stopped, having that discussion around what's next.
Yeah, absolutely. That's good advice. Obviously, we haven't had time here to talk about some of the other drugs like raloxifene or strontium or even HRT, but we know that these drugs work whilst you're taking them. And if you stop them, you may need to have a discussion with your doctor about eventually moving on to something else, and obviously assessing your risk of fractures, as we've discussed. One thing we do also get people sometimes asking us about is that people say their doctors told them they can only stay on their treatment for 3 years. And this is something that's come from some guidance from NICE. And if people don't know, NICE is the National Institute for Health and Care Excellence. They're the people who make decisions about drug treatments that the NHS prescribes and uses, and other therapies given. Have you got anything to sort of say about that?
I think this is obviously NICE give guidance, and the reality is that, like I said at the top, each patient is different, and there'll be those, what's right for one patient isn't necessarily right for another. So it really is having all that information on the table, weighing up the risks and the benefits of any particular approach. And having those discussions, if you don't feel informed or around things, having those discussions with your healthcare provider. But there are, many people are on treatments for longer than 3 years, but these things should be sort of active decisions, where you've got that where the patient has got that understanding of why a particular approach is being taken.
Absolutely. So yeah, the reassurance that it's not unsafe if their doctor says they can stay on for longer. Absolutely.
Yeah.
That's good.
Yeah.
Well, that's a really, really useful summary of this topic, but I think this is going to be something that's much watched because we have so many questions about this on a regular basis to the helpline. So thank you so much, Zaki. That's been brilliant.
Thanks so much.
Oh, no problem at all. Of course, for people out there watching, you can find out more information on our website about all of the drug treatments, and also there's some information on there about how decisions are made on how long you do stay on different osteoporosis medications. So I hope this has been helpful, and thank you for watching.
Thank you.